ejection fraction, 5-year
Five-year
outcomes
outcomes
from the
reduced
reduced
by
HF2 trial. Sanjiv.
Great, thank you, Clyde, and the rest of the panel. Really excited to show you the final 5-year outcomes from the reduced LAP HF2 trial. Here are my disclosures. So I'm sure you're all aware of the Corvia Atrial Shunt. It's the first shunt to undergo a pivotal trial that has been completed now, and we have the 5-year data. Grant Reed already told you that this is a randomized double-blind sham-controlled trial of 621 patients. 93% had HFpEF, so mostly a HFpEF trial, and exercise right heart cath was required in all. The primary result, as Grant said, was neutral, but we did find a responder group with pre-specified and post-hoc subgroup analyses, and these were those that had a peak PVR less than 1.74 and no cardiac rhythm management device. And we saw benefit at 1, 2, and 3 years, but there's this persistent question if the patients randomized to shunt will have late right-sided heart failure, and the outcomes will diminish, particularly in the responder group, which is where we're following up in the responder trial. So does the benefit persist to 5 years, and are there long-term safety concerns? So the methods, these are the final 5-year results. I had previously presented last year some prelim data, but we only had about 50% of the 5-year data. Now we have the full. We did exclude those that crossed over. 43 patients crossed over at the 2-year visit. The primary composite endpoint was the win ratio, which was a combination of cardiovascular death, non-fatal ischemic stroke, total first and recurrent heart failure events, and change in KCCQ overall summary score. So as you can see here, there was 626 originally randomized. 5 were excluded. They didn't get the implant. And we also excluded the crossover, as I said. So the 5-year analytic population was 578 participants. And then we report that data, and then we divide into the responders and non-responders. So here are the results. We continue to see that in all patients, there's a win ratio of about 1.0, didn't change at 5 years. And there's still a big difference between responders who had a 1.48 win ratio, so quite a bit of improvement, statistically significant, and the opposite in the non-responders, and that's kind of what we've seen all along, and that persisted to 5 years. Now you can see that components of the primary endpoint that they look pretty neutral in all patients. There was an initial worry about stroke, but that seems to be really isolated to the non-responders. In the responders, the heart failure event rate and KCCQ remained persistently improved, as I'll show you in a few minutes. So these are drilled down in the responders. So you can see that there was really no difference in cardiovascular death or non-fatal ischemic stroke. CV death and non-fatal ischemic stroke were about the same in both groups. But the heart failure event did go down. The percentage that had a first heart failure event was 22% in the shunt arm and 34% in the sham control arm. And you can see that there was about a 10-point greater improvement in KCCQ OSS. And again, the win ratio is 1.48. Here's the time to first event. You can see that the curves split early and remained split over time over the 5 years. The number needed to treat is 9. The absolute risk reduction was 11.7%. And when you look at cumulative total heart failure events, again, we don't see a catching up of the atrial shunt arm in the responder group. So they're not having late right-sided heart failure events and highly significant still at 5 years. Now, CV death and non-fatal ischemic stroke, these were very small numbers. You can see that there was some early strokes in the atrial shunt arm, but the sham control caught up as the study went on. And we don't really think that there's a difference other than chance alone here based on the events that we saw. Now you can see that KCCQ was quite different between the two groups. There's this big splay in the data, as there usually is with KCCQ, but you can see that in terms of a major improvement, 47%, nearly half of the patients in the responder arm that were randomized to the shunt had a greater than or equal to 20-point improvement, and the odds ratio for that was 2.3. Safety results, there were really no differences in the entire population of the patients. In the responder group, There was about similar across the board, except for new onset or worsening kidney dysfunction. There was a trend towards less renal dysfunction in that group, and we think that's consistent with more heart failure events in the sham control arm. Now, in the non-responder group, there were some differences in outcomes. There was a trend towards a worse composite safety, 40% versus 28%, and numerically higher stroke. And the V-Wave Relieve HF trial that came out after our trial really kind of, I think, settled this because their HFpEF group was even sicker than our non-responders. So it really seems like there is a group that doesn't respond and doesn't do well. So in conclusion, in the overall trial cohort of reduced LAP-HF2 at 5 years was still neutral. But in the responder group, which is currently being validated prospectively in the responder HF trial, there was remained a significant benefit on primary composite outcome, a 34% relative reduction in heart failure events, twofold greater improvement in KCCQ OSS, and no safety concerns through 5 years of follow-up, whereas the non-responders seem to have worse heart failure outcomes and a trend towards worse safety. So patient selection, we think, is very important based on exercise hemodynamics. We think it's essential for optimal outcomes for atrial shunting and HFpEF. Thank you.
One question, Nancy.
Sanjiv, that's very reassuring. Did you look at the right heart at all at 5 years?
Yeah, we don't have echo data on up to 5 years. We have it up to 2 years, and we published that in JAMA Cardiology a few years ago. And really across the board, it was interesting, at 2 years, you don't see a lot of RV dysfunction at all, even in the non-responders. So it's kind of interesting. We're going back through each heart failure event, and there are isolated cases where you see that there's volume overload and right-sided heart failure. You know, we published a case series on some of these cases. Closing the shunt was not the right, in 4 of the 5 cases. It's really optimizing volume control. So it's interesting. We're just not seeing it. What's really causing the heart failure events really seems like it's these acute rises and inability to augment cardiac output if you're in the non-responder group.
I want to thank all the presenters today for a really outstanding late-breaking clinical trial session. A lot of new science, a lot of